Hello everyone, I'm Dr. Jason Chen. I am the consultant for inpatient diabetes. Today we would like to talk about diabetic keto acidosis, a serious diabetes complication that can make people with type 1 diabetes very unwell, especially if they're not being managed appropriately. The following DKA5 will help you to remember the 5 key things that's important to reverse the diabetic ketoacidosis and make these patients with type 1 diabetes better. 2F at the start, 5M at the heart. I have my colleague, acute medicine registrar Dr. Alex Matharka, and also Amy Harris, diabetes inpatient specialist nurse, who will go through the 5 key things with you.
Perfect. Thank you, Dr. Chen. So in terms of our initial diagnosis, I will cover the start points for the management of the protocol. When a patient comes into the hospital, we need to identify diabetic ketoacidosis firstly. So we identify it by looking for a blood glucose level of over 11, blood ketones of over 3 or 2+ in the urine, and a pH of less than 7.3. Once we've made our diagnosis of diabetic ketoacidosis, this poster can run us through every step in the process. This is a very systematic process, and it can be managed as simply as sepsis is managed now. Our 2 F's at the start to begin with include our initial fluid management and our fixed rate infusion of insulin. Firstly, to mention, our initial fluids are taken and are determined by the blood pressure of the patient. So if the blood pressure is less than 90 systolic, the patient will need a fast bolus of fluid. That bolus is 500 mils of normal saline, 0.9%, over 10 to 15 minutes. If the blood pressure increases to over 90 systolic, we can continue from the first step 1 of the protocol. If the blood pressure is still less than 90 after 1 bolus of fluid, a further bolus should be administered. If multiple boluses of fluid are required, this is an indication that the patient is more unwell and there may be a significant trigger to the DKA that might not be well managed ultimately on the wards, and therefore escalation and senior input is important at this stage. When we move on to our first step in the fluid management, once the blood pressure is over 90 systolic, our first bag of fluids is 0.9% saline over 1 hour administered as a fast bolus. Alongside this, having made our diagnosis, we need to start our insulin infusion. The insulin is a fixed rate of insulin administered at 0.1 units per kilogram per hour. For the average adult, that would be approximately 7 units if they weigh 70 kilograms. It's important to remember for patients with DKA, they are likely on long-term insulin, and therefore their long-acting insulin should be given in the background at its usual times. If the patient has already had their morning dose, we can start from the evening and consider the patient to continue their usual regime from their first evening dose. If they haven't had their morning dose, then a stat dose followed by restarting their normal long-acting insulin regime in the evenings is appropriate. Once the patient has been started on a fixed rate insulin infusion and their initial fluids have been administered, it's very, very important to get them on the correct monitoring protocol.
It is vital as part of DKA management that we are monitoring these patients very closely. Fortunately, there is a really good monitoring chart that we should be using. This should be used to monitor the patient's blood glucose, which should be done hourly, the blood ketones, the rate of insulin running as a fixed rate, the mils per hour of fluids running. You need to be monitoring the urine output. If within an hour the patient has passed no urine or the patient is incontinent, you might think about popping a catheter in, the venous pH, the potassium and the bicarb. The reason it's so important that we're tracking these elements is to make sure we escalating if they're not improved. For example, if you're tracking the blood glucose, we should be aiming for it to be falling by 3 millimoles per hour. For the ketones, we should be looking at decreasing by 0.5 millimoles per hour. The fluids are essential that we're monitoring alongside the urine output, as there is a risk of pulmonary edema and other forms of overload. The venous pH should be increasing. If it's not increasing, then you might need to escalate the treatment plan. Also, it's vital that we track the patient's potassium, and when you're looking at the potassium levels, you might need to be considering what type of fluids they're having. For example, hypo and hyperkalemia are big risks when someone is on a fixed rate insulin, and the bicarb should be increasing by approximately 3 millimoles an hour also. If you're not achieving this, then you might need to seek extra help. For example, you might need to escalate it to your ITU doctor.
In terms of our monitoring regime, the chart that has just been described can be found in the A&E department in the drawers in Resus, and it can also be found on the AMU eye doctor's office. It is important, very, very important, that the first initial blood gas is recorded on this chart, as this defines all of the next steps in the monitoring. Blood gases can then be carried out, as the poster shows, at 2 hours, 4 hours, 6 hours, 12 hours, 18 hours, and then 24 hours. If the pH is not dropping on a repeat blood gas, then they should be carried out hourly until we switch into the regime of 2 hours, 4 hours, 6 hours, 12 hours, 18 hours. So we wait until the pH is dropping before we switch onto that monitoring regime. And the importance of this chart defines our whole monitoring regime throughout the patient's time on DKA, being managed for DKA. The maintenance fluids are run directly from our monitoring and from what the potassium is showing us on the monitoring. Initially, fluids should be given at 2 hourly, then further 2 hourly bag, followed by a 4 hourly bag. The amount of potassium within these bags will be defined by the potassium that is recorded on the VBGs. If the potassium is less than 3.5, we will need a senior review, and we may need more rapid potassium than 2 hourly or 4 hourly, or more concentrated potassium, and therefore that's an indication the patient may need to go to a high dependency area. If the potassium is between 3.5 and 5.5, then 40 millimoles of potassium is given in the sodium bag. If the potassium is greater than 5.5, no potassium is given. It's important also to monitor for the blood glucose levels and the ketone levels hourly, and if they are dropping, the patient should be started on glucose 10% alongside their sodium potassium fluid management. This should be started if the blood glucose drops below 14. An appropriate prescription looks like this on the drug chart. It's really important that if you're going to write a prescription like this for the initial fluids, that the potassium is checked very regularly, and the caveat is placed that if the potassium is between 3.5 and 5.5, we can give 40 millimoles. If the potassium goes above or below this range, as the poster describes, we need to react to that, and therefore our monitoring is crucial. Our management aims is to bring the blood ketones down by 0.5 millimoles per hour, to bring the bicarbonate up by 3 millimoles per hour, and for our blood glucose to drop by at least 3 millimoles per hour. If we're not achieving these management aims, we need to consider that the patient either isn't receiving their insulin, i.e. their lines are not working effectively and they may need further IV access, or they may need an increase in the insulin that they're receiving because it's not sufficient to meet these target aims, and therefore increasing the fixed rate infusion by 1 to 2 units is appropriate. Life-threatening dangers of DKA exist, and it's important patients are not started on treatment and left without monitoring. The life-threatening dangers include edematous-related changes, that is cerebral edema and pulmonary edema, as well as electrolyte imbalances, for example, hypo or hyperkalemia. Monitoring from this point of view is crucial and will be picked up with the blood gases. Cerebral edema occurs in the extremes of ages, that being the very young patients and the older patients, and therefore looking for signs of a reduced GCS in these patient populations is crucial, and escalation is crucial if these signs are picked up, because it may indicate that cerebral edema has occurred. Further fluid overload can occur, particularly, for example, in congestive heart failure, which can lead to pulmonary edema, leading to reduced saturations, and tachypnea, which should also be picked up on routine observations. The purpose of this video is to show that DKA can be managed in a very systematic way, very similar to sepsis. There are 5 main points, and this poster shows all of these points, and you don't need more information than what is on this poster and what is on the monitoring chart that we have available also in the trust.
Remember, DKA5, fluid resuscitation at the beginning, fixed rate intravenous insulin infusion, monitoring of the key parameters, pH, bicarbonate, blood glucose, blood ketone, and clinical responses. Further fluid maintenance. And lastly, remember, you want the patient to get better with the management goal of gradual improvement of the blood glucose, acidosis, and ketosis.
Thank you.
Thank you.